This topic is acute kidney injury, also known as AKI. For us to better understand AKI, let's first review the renal system and how it works. Everything in the renal system starts with the kidneys, which help to filter waste from the blood in our body. As the kidneys begin to filter this waste, they can also choose to reabsorb water and electrolytes or eliminate them along with the waste in the form of urine. When waste is filtered through the nephrons, it deposits in the renal calyces and eventually collects within the renal pelvis. Urine then travels from each kidney down both lengths of each ureter and eventually collects within the bladder. In the bladder, the urine is stored until we are ready to eliminate it via the process of urination, where it leaves the urethra. Most of the time, this process occurs unimpeded. However, several complications can occur that lead to the development of acute kidney injury. These complications are classified as pre-renal, meaning happening before the kidney or inside some other part of the body, intrarenal, meaning something is occurring within the kidney itself, or post-renal, meaning that something is affecting some other part of the renal system that is not the kidneys. We'll take a closer look at these causes of AKI on further slides. AKI is an abrupt decline in kidney function that results in the impairment of waste elimination and contributes to the development of imbalances in fluids and electrolytes within the body. Like I mentioned earlier, AKI has pre-renal, intrarenal, or post-renal causes. Pre-renal causes are factors that affect kidney function outside of the renal system and are usually a result of a decrease in blood flow to the kidneys. This image here depicts a nephron, and we can see blood vessels connected to the glomerulus. If blood flow decreases to the glomerulus or other parts of the nephron, this can lead to tissue impairment and evolve into kidney dysfunction. Intrarenal causes are factors associated with direct injury to the kidney tissue itself. The kidney is made of nephrons, which consist of glomeruli and tubules. So if we have conditions like glomerulonephritis, which is inflammation of the glomeruli, or tubular necrosis, which can occur from ingestion of certain chemicals, drugs, or tissue ischemia to the tubule itself, can lead to the development of kidney tissue damage and kidney dysfunction. Post-renal causes are factors that cause a backflow of urine into the kidneys and cause increased pressure within the renal pelvis and renal calyces. This increase in pressure within the kidneys will cause a decrease in blood flow and ultimately result in kidney dysfunction. Two common causes of post-renal AKI are benign prostatic hyperplasia and ureteral stone obstruction. Now, benign prostatic hyperplasia, or BPH, is an obstruction that occurs within the urethra, leading to buildup of urine into the bladder and can eventually back up through the ureters into both kidneys. While a ureteral stone is only going to affect one ureter and one kidney, however, both instances can lead to acute kidney injury. Clinical features of AKI occur in 3 stages. The first stage is the initial stage, where the client may have some subtle symptoms, but should still have some urine elimination. One way we can monitor for whether or not the client is developing AKI is to see if they have a slight increase in BUN and creatinine levels. BUN and creatinine are waste products that are eliminated by the kidneys and can be correlated and associated with overall kidney function. The second phase is the oliguric, meaning low urine output, or anuric, meaning no urine output. And this phase is characterized by urine output that's less than 500 milliliters in a 24-hour period of time, a progressive increase in BUN and creatinine levels, an increase in serum urea levels, which is a waste product, again, that's typically eliminated by the kidneys. This results in uremia, which can cause symptoms of anorexia, nausea, vomiting, and pruritus. Metabolic acidosis can occur due to the kidney's inability to filter waste products and eliminate excess hydrogen ions. This buildup of hydrogen ions will essentially decrease our serum bicarbonate levels, or HCO3. One way the client may try to get rid of excess acid within the body is by breathing it out in the form of carbon dioxide. This may present in the form of Kussmaul respirations, which are rapid and deep respirations. Due to decreased kidney function and elimination of urine, the client may develop hypervolemia. Essentially, they have an abnormal increase in circulating fluid volume, which can lead to the development of hypertension and eventually can cause things like peripheral edema or pulmonary edema due to leaking of fluid from the blood vessels. And because electrolyte elimination is impaired with this client, we can expect an increase in overall electrolyte levels and can expect to see things like hyperkalemia and hyperphosphatemia. Following the second phase, we enter the third and last phase, which is the diuretic phase. In this phase, the kidney's glomerular function has slowly returned. However, because the kidney's tubules are affected and are unable to concentrate waste appropriately, this results in heavy diuresis and fluid volume loss. This phase is characterized by a slow increase in urine output, followed by heavy diuresis of up to 4 to 5 liters per day. This can result in fluid and electrolyte losses and ultimately result in hypovolemia and hypokalemia. We should see BUN and creatinine levels start to decrease, and kidney function returns to normal or near normal gradually. Interventions include correcting the underlying cause, whether that's a pre-renal, intrarenal, or post-renal cause. If the client has a kidney infection, we want to administer antibiotics. Or if the client has an obstruction, we want to reduce or eliminate that obstruction to improve urine flow, which will essentially help when it comes to increasing blood flow back to the kidneys. Use of nephrotoxic medications should be avoided, and if the client is taking nonsteroidal anti-inflammatory drugs or aminoglycoside antibiotics, such as gentamicin, these should be discontinued. Because many medications are eliminated by the kidneys, we may need to consider medication dosage adjustments, especially in the case of decreased elimination when it comes to the oliguric or anuric phase, or increased elimination when it comes to the diuretic phase. Even if the medication is not nephrotoxic, we may need to adjust the medication dosage to avoid accumulation. On a similar note, we will need to monitor for strict intake and output, as well as any fluid or electrolyte imbalances that may occur. This is where it becomes very important to know whether the client is experiencing symptoms associated with the oliguric or anuric phase versus the diuretic phase. In the oliguric anuric phase, the client will be retaining fluids and electrolytes, meaning these will be elevated and the client is more likely to have things like pulmonary edema and hypertension, as well as hyperkalemia and hyperphosphatemia. In contrast, if the client is in the diuretic phase, we're losing fluids and electrolytes, so we should monitor for low blood pressures as well as decreases in electrolyte levels like hypokalemia. For the oliguric anuric phase, we should monitor lung sounds for the presence of crackles and the blood pressure for hypertension. Additionally, due to the buildup of potassium, we want to administer a potassium-restricted diet to avoid any further increases in serum potassium levels. Daily weights and renal function should be monitored frequently to assess for any weight gain or loss, as well as an improvement or decline in kidney function. And lastly, if kidney function has become significantly impaired, the client may need temporary or permanent hemodialysis to remove excess fluids and monitor electrolyte levels.